Estrogens are pivotal regulators of brain function, exerting profound effects from early embryonic development to aging. Extensive experimental evidence underscores the multifaceted protective roles of estrogens on neurons and neurotransmitter systems, particularly in the context of Alzheimer's disease. Studies have consistently revealed a greater risk of Alzheimer's disease development in women compared to men, with postmenopausal women exhibiting heightened susceptibility. This connection between hormone levels and long-term estrogen deprivation highlights the significance of estrogen signaling in Alzheimer's disease progression. The pathogenesis, the process by which a disease develops, of Alzheimer's begins with the breakdown of the amyloid precursor proteins to produce beta amyloid, which accumulates around the cerebral blood vessels, forming amyloid plaques. Amyloid plaques weaken the vessel walls, leading to intracranial hemorrhage. Besides this, beta amyloid also has a neurotoxic effect on the brain, destroying neurons and causing atrophy of the cortex. In addition, beta amyloid accumulation in the nucleus of the forebrain causes the loss of acetylcholine, the neurotransmitter essential for memory and learning. Patients with dementia experience a progressive decline in neurocognitive function, beginning with short-term memory loss that progresses to long-term memory loss and the inability to perform everyday activities, leading ultimately to death. There is currently no cure for dementia, so preventing or slowing the disease's progression is paramount. Accordingly, researchers have studied the role of estrogen as a neuroprotective agent. Estrogen prevents dementia by augmenting hippocampal and prefrontal cortex function in the brain, reducing neuroinflammation, preventing degradation of estrogen receptors, decreasing oxidative damage to the brain, and increasing acetylcholine and serotonin neurotransmitter function. Interestingly, studies on the use of hormone replacement therapy in postmenopausal women suggest a protective effect against cognitive decline, specifically maintenance of brain tissue integrity with hormone replacement therapy. They suggest that supplemental estrogen protects cognition in multiple ways by promoting acetylcholine activity, protecting the brain from toxic insult, stimulating neuron synthesis, and reducing deposition and enhancing the clearance of beta amyloid, the main constituent of the amyloid plaques seen in Alzheimer's disease. The effects of hormone replacement therapy can be complex. Long-term estrogen therapy appears to be beneficial in slowing the progression of Alzheimer's, but it is usually combined with a synthetic progestin in women with an intact uterus to prevent endometrial cancer. Synthetic progestins can suppress memory, especially in older women. Research suggests that unlike synthetic progestins, natural progesterone does not have this negative impact on memory. Multiple studies indicate that there is an optimal period, or rather, a window of opportunity. Window phase hypothesis for prescribing estrogen therapy that results in better cognitive outcomes in postmenopausal women. This period is hypothesized to be during perimenopause or right after menopause, specifically during the first 5 years. There are several factors that could explain this. First, a long premenopausal phase when significant levels of estrogen continue to be naturally produced is associated with greater cognitive function and a decreased risk of Alzheimer's disease. The risk of Alzheimer's disease is reduced by 0.5% for every additional month of estrogen exposure before menopause. Second, there is a reduction in the number and affinity of estrogen receptors, especially estrogen receptor alpha, with the prolongation of the hypoestrogenic phase associated with menopause. Patients with Alzheimer's exhibit a straight-line declining relationship between the number of estrogen alpha receptors and cognitive function, which further supports the idea of estrogen alpha receptor degradation leads to a less than optimal response to hormone therapy, when therapy is initiated after the 5-year window of opportunity. Starting estrogen later in life, for example after age 65, does not appear to be beneficial,